You want to put up the agenda?
Absolutely. Okay. Here we are.
Okay, so I just wanted to do a quick welcome, and if you can put the prior slide, I think.
Yeah, I'm sorry, I was moving too much. Okay.
Okay, so this is our opening meeting for the AKI Workgroup for VCSQI. I'm really excited about this project. I wanted to just say a quick hello and a thank you for being involved. And then what I'd like to do is for each of us to kind of introduce ourselves to the group. Many of us know each other, but nonetheless, who you are, what you do, where you do it, that kind of thing. And then in that discussion of your introduction, please let us know what you want to get out of the work group. What are your expectations so we can manage the expectations? And then we'll spend some time talking about brainstorming and projects and then next steps. Excuse me. Thank you. And then lastly, those people that are interested in taking the lead for the group, probably a couple people as co-chairs would be perfect. It will not be me, but I did want to just start with the welcome and the discussion. I'm Bob Shore. I'm part of Virginia Heart. Been in practice for 30 years and plus years, and in part of we have a close affiliation and relationship with ANOVA, and particularly the Heart and Vascular Institute. So that's, and as well, I'm chair of VCSQI at this point. Very important that we're merging the cardiology and the cardiothoracic surgery portions because of the continuum of care that we are all experiencing. I am a reformed interventionalist, so I'm out of the lab, but that's what I did for many, many, many years. Okay, based on the top, why don't we just start from the top down? Is James here?
Yes, hi, good afternoon, everyone. Yes, I'm James Gregory, nurse director here at St. Mary's, been at St. Mary's here for going on 23 years. I've been in the clinical arena, worked collaboratively with some lean projects that we had done to decrease acute kidney injury. So along with our physician colleagues, and really made a lot of really good progress in that area. So happy to work with the group here, and I just hope to learn something new and hopefully update our practices. It's been quite a while. It's been a few years since we updated our hydration protocol. So, but also happy to share anything with the group. So in a collaborative way. Thank you.
Nancy? Not sure if Nancy's on.
No, Nancy is not on the line.
Okay, is Miriam on the line?
No, she is not. The next person on the list, actually, Mike Brown.
Mike, let me just add before Mike starts talking that when we looked at the data, as you all well know, from the cardiothoracic surgery standpoint, one of the biggest impacts is from a complication standpoint that impacts both quality of care and cost is acute kidney injury. And so that's why we really wanted to pursue this as a frontier. So go ahead, Mike.
Hi, my name is Mike Brown. I'm a perfusionist at Mary Washington Hospital. For the last 11, 12 years, I've been the program manager for cardiothoracic surgery, and also the last 4 years for structural heart. And I'm still an active perfusionist in my group of 4 and the chief of that group. We had started a AKI reduction kind of task force about 2 months ago. And the first month was spent really just getting facts together and trying to get a list of action items that we could kind of address for our service line. One of the things that kind of, I don't want to say stalled us out, but we kind of paused our group was just the fact that the Society of Thoracic Surgeons and the Society of Cardiothoracic Anesthesia are actually currently working on a consensus recommendation for AKI prevention and cardiac surgery. So we haven't met within the last probably 3-4 weeks, just in anticipation of that. When I was on the perfusion group conference call last month, Sherry had recognized the work group, the new work group, and had said that they were looking for somebody to help lead that process. And I thought, for me, it would be good because I'm not sure that I'm a thought leader in AKI prevention, but I thought that really for us, it's something that we're really focused on, and it would help us, within our program, as well as be a contribution to VCSQI. So the one thing that I really think is great about having the cardiology and cardiac surgery side now together in VCSQI is this fact that we can now begin to work together to develop protocols, because we kind of worked in silos before. And while cardiac surgery and cardiology and many institutions work together, I don't know that we've had the opportunity like this as an organization to say, hey, what are some ways that we can help each other with our outcomes? And I think this will be a tremendous opportunity. And I will say that if anybody has a desire, small or gigantic, to lead this group instead of me, I'm more than happy to kind of support the group in any way I can. But I thought this would be a good opportunity to be involved. So, and that's all I got to say.
Thank you so much, Mike.
Unless my cat has something to say, which right now she seems to be immersed in
So Mike,
something else.
we're trying to optimize perfusion and come up with common protocols between cardiology and cardiothoracic surgery. That's what you'd like to see out of.
Well, I would. I think there's definitely an opportunity with hydration protocols. I think that's a huge opportunity. And the other thing that we really picked up on in doing our literature search was blood pressure control in those hypertensive patient populations during the post-cath, the post-cath consult, surgical consult time period, and then the intra-op and post-op. There is some literature that's come out in the last 3-4 years that talks about pulse pressure hypertension and those people who run around with a systolic pressure of 130, 140, a mean of 90, and then get in the operating room. And are we really addressing that? And those patients we know are very much at a high risk for AKI. So I think the combination of working with cardiology on those measures, I think would be a good start. And then the other part is transfusion. I know there's been some literature discussing whether elderly females who are diabetic and anemic, hemoglobin less than 10, those people are very much at a risk for AKI. And so, how far do we drill down and get into the weeds to develop this protocol? I don't know, but I think there's definitely a variety of options that we have out there that we can include in the protocol.
Okay. Excellent. Thank you, Mike. Next in introductions, we have Dr. Kevin Lobdell from Perfect Care.
Thanks, Sherry. Can you hear me okay?
Yes, perfect.
Great. Yeah, Bob, Alan, and then certainly sort of tactically, Eddie and Sherry and I have spent time talking about connecting Perfect Care, and in many ways mirrors what Virginia's been at for years and done so well, and a few novel items. My clinical background is in cardiac surgery, both adult and congenital. I've spent over a decade or a decade and a half in cardiac critical care. And over, say, 10 years, directly involved with quality. I now direct quality education and research for our system, where we have 6 cardiac surgery programs. We're working through Perfect Care on many of those things that you've done in Virginia, but also growing the network together. So that's something that we're having ongoing discussions about. Zeroing right in on acute renal failure, I'll give you sort of a clinical history. When I got to Charlotte in 2004, we had a renal failure rate. And when I give you these numbers and sort of the history, CAB only, because historically that was somewhere around 60-65% of our cases, and the easiest thing to look at and compare. We had a renal failure rate there that was about 3 times the national average, meaning 3 times higher than the national average, and worked on goal-directed therapy and early extubation, glycemic control, all the things that we now call ERAS, and were a part of our quality improvement program. By 2014, 10 years later, we had 0 renal failure. And if you looked at the line over time, it was about as close as you'll ever see to a perfect fit line. So it wasn't like we drew a line and the dots were all over the place and we finally got to 0. It was really a great body of work by a lot of people over a period of time. Just to give you a longitudinal view of that too, if you take 14 and 15, I think our total was 0.3%. So we were around 8-9 times better than the national average at that point. I will tell you that since I've had less direct clinical work and more system quality work, I think some of that has migrated. It's hard to tell exactly why, but it's still something we do well. And Michael mentioned the STS effort, and I currently chair that writing effort on the guidelines. I inherited that late in the game. So that is to come out soon. I'm part of ERAS as their treasurer. And as far as, how do I help? I think the answer is, how do I help? I don't see myself chairing this or leading this or anything of that nature, but I'll try to help with experience and expertise wherever I can.
As always, thank you, Dr. Lobdell. Okay,
That's
up
fine.
next. Oh, go ahead. Dr. Shore, you wanted to say something?
No, I was just saying, thank you. No, I was saying that's fabulous and very welcome to and needed for the group.
Yes. Okay, we're going to jump down to UVA. Up next, we have Dr. Nick Tiemann.
Yeah, hi everyone. So I'm Nick Tiemann. I'm one of the cardiac surgeons at the University of Virginia. I'm also one of the intensivists in our cardiothoracic and vascular ICU. I'm actually the medical director of that ICU. So that's kind of my primary interest in terms of this group here is lowering our AKI rates in our postoperative cardiac surgery patients. So excited to work with the group and learn from others and from what others have been doing well, and share some of our insights here as well.
It's a pleasure to have you. Thank you. Up next from UVA, we have Eve Dallas. Okay, she may not be available at the moment.
Am I there?
Yes,
Okay.
you're here. Great.
Okay, sorry about that. Yeah, so I'm Eve Dallas. I'm a perfusionist at UVA. I've been a perfusionist for 20 years. I've been at UVA for a little bit over about 4.5 years. I've been active on the UVA AKI Risk Reduction Committee for, I think probably about 3 years. And I'm currently the chair of the VCSQI Perfusion Group, a new work group that we formed that Mike alluded to a little bit earlier. I guess I'm just here to try to provide the perspective of perfusion when we're collaborating with all of our peripheral groups and make sure that our interventions and practices that are pertinent to bypass and AKI have the voice of the perfusionist.
Excellent. Thank you. Thank you, Eve. Okay, up next from UVA, we have Dr. John Kern.
Yeah, hello everyone. I'm John Kern. I'm one of the cardiac surgeons at UVA, and I don't have much more to add other than what Nick Tiemann and Mike had to say in terms of developing successful protocols that can be durable over time. And I really look forward to the input and experience and expertise of Kevin. So appreciate this opportunity.
Thank you so much. Up next, also from UVA, we have Judy Smith. Okay, we'll give her a moment to see if she can unmute. We're going to jump down to Winchester. And at Winchester, we have our very own Chris Seisma.
All right, Sherry, can you hear me?
Perfect.
Okay, great.
Now we can't hear you, Chris. Chris, try to unmute one more time.
Can you hear me now?
Perfect.
Okay, I'm sorry. I don't know what's going on here. But anyway, I'm the Director of Outcomes at Winchester. Been here about 40 years, and I have worked in almost every aspect, including the cath lab, just not the OR, and seen a lot of changes. And we were very, very proud of our renal failure rates for our cardiac surgery population until we saw the data that was presented by Eddie looking at AKI rates and the PCI population and the CABG population. And what we realized is that we really were not faring very well there. So we started looking at our infusion protocol for fluid resuscitation, but we thought that's still just in our one area. So we have very excited to have the opportunity to do this with the VCSQI, looking at really scientific data and actually scientific protocols to help our renal failure rates and our AKI.
Thank you, Chris. And Judy, I see
Hi,
you.
Sherry.
Hi.
Yeah, I go, hi, it's Judy. I'm interested in everything about AKI, and I definitely think to come out of this group, like goal-directed therapy and managing like that walking around blood pressure thing, like what Mike was talking about, but anything we can do.
Sounds good. And last but not least, we have Kim Roberts.
Hello, good afternoon. This is Kim Roberts. I'm a cardiac anesthesiologist at Mary Washington Hospital, and I'm here through the invitation of Mike Brown. He and I have worked together at Mary Washington for about 17 years. And most recently, we've been working on, as Mike described, the AKI work group at Mary Washington to try to improve our outcomes. And I am interested in specifically what we can come up with for standards of care surrounding the anesthesia and intraoperative management for our patients.
Thank you so much. It's a pleasure to have you all. Dr. Shura, I'll toss it back to you. I believe that's everyone we have. Yeah, everyone is accounted for.
Great. So I guess we can go back to the next slide. Yeah, so two other things. One is in your institution, if there are cardiologists that you think might be interested in this too, to make sure that we have the continuity from cath lab to the OR covered, would be great. So think about it, talk to your colleagues, and then let Sherry know. The second is I wanted to show the next slide just to, before we go, go back. There we go. So we did have a brief survey that we really want to flush out a little bit more as to whether or not your organization has an AKI protocol in place. And these are the yes, no, but interested, and not at this point. And this seems to be probably both incomplete and not entirely accurate. We probably need to make sure that we are doing both cardiology and cardiothoracic surgery as we are merging the two. And at this point, I just want to open it up to folks to talk about what they'd like to do from this point moving forward, sending a survey out, coming up with ideas, common programs we can try to initiate, et cetera.
If it's possible, Sherry, can I speak?
Please.
So, from our initial committee meeting, one of the things that we really just focused on was breaking out those work areas, which was, from cath to procedure, cath to cardiac surgery, and then that intraoperative component, and then that postoperative component. And we broke down into those areas and identified, some opportunities for improvement. One of the other things that we did is just looked at some of the predicting models. The Cleveland Clinic has a cardiac surgery prediction model, AKI prediction model, and trying to determine if there's any value in using that as a standard of care preoperatively to assess risk. Some of the things that that we looked at from an intraoperative standpoint, which I think would be helpful for us to get a nephrologist involved if possible. We invited one of our nephrologists to just provide some advice to us as far as are we missing something from nephrotoxic drug standpoint, from a hydration standpoint, and also from a transfusion standpoint. I know that transfusion's been associated with AKI, but it's also been, anemia has also been associated with AKI. So these things were all kind of in that pre-op and then that intra-op component, in addition to blood pressure control. And then we also broke that intra-op part down into kind of like an anesthesia management and perfusion management, trying to look to see, are there opportunities from a perfusion management standpoint, DO2 monitoring? Is there a minimum hemoglobin that we should be at for patients who are, elderly diabetic? The elderly diabetic female anemic has been very much associated with AKI. And so looking at that patient population, and then in the post-op patient period, looking at blood pressure control, use of vasoactives, selection of pressors, hydration, and versus diuresis, and trying to get a better handle on what are best practices for those things. That's a lot to do. And I think it's going to probably require us to break out maybe into different subgroups. But that's kind of where we started off with our work groups. I'm very much open to anybody's thoughts on those things.
Mike, I think the input of a nephrologist is really good. And, here at UVA, perhaps like a lot of places, we've seen our AKI go up and down depending on our level of attention and institution of new things. But I've been disappointed in that when we make progress, it's not sustained progress. And the one time that we did have sustained progress was when we did have the input of a dedicated, engaged nephrologist being involved preoperatively and then throughout the continuum of care post-op.
Is there a possibility that Dr. Brooks might be willing to, serve as a kind of an adjunct advisor to the group?
I don't think he'll be able to due to reasons beyond our control.
Okay. If there's anybody on the call who feels comfortable or confident that there's a nephrologist that, that's, supported their practice who wants to invite that person, I think that would be great. And I'll reach out to the nephrologist who's helping us and see if he'd be willing to, review whatever measures that we develop and also maybe sit in on the calls moving forward.
Like Brendan Bowman talked to us at our quality group. I mean, that might be an option. I'm like, he knows the group, and I could certainly ask him. Or
Who's that?
Brendan Bowman. He spoke to the group. I don't know if you were there for that meeting, but he talked about AKI at one of the quality meetings for VCSQI.
Yeah,
I don't know how Dr. Kern feels about that, but I mean, like he seemed to be engaged and
nephrologist.
Willing. Yes, sir.
Yeah, I think it'd be great if you guys think it would be a good addition. Yeah, I'm very supportive of that. The other thing I wanted to bring up, because I know that they presented at previous meetings, and I believe you guys may have done a short study, or was the blood test for the that predicted risk of AKI. Are you still doing that at UVA? The NephroCheck?
Yeah, it's a urine test, and Nick may want to speak to this. It's not very popular because you can see people with just horrible AKI and their NephroCheck's fine. So you're trying to wrap your head around, how do you have like a perfect NephroCheck but you're, you see in somebody in fulminant renal failure. We think there's an element of, it takes a while for your creatinine to go high, right? So that maybe at that point, it's just one point in time. That maybe at that exact point in time they were okay, and then their kidneys died, had stress like a day before, 2 days before. I'm not sure we'll even renew the contract. I think we're working on it with the team. We have it until December of 2021. It is a snapshot in time, and it's really more like at first I think I kind of thought of it like a troponin for your kidney, but it's really more like a lactic acid for your kidney. Like, is your kidney happy or not happy?
Yeah.
I think Nick can probably talk better to, the team's having a hard time with it, I think.
Yeah, and I've heard that it really depends a lot on the timing of the test, and I think, Ken, to what Dr. Kern was saying, a lot of the protocols that we put together through VCSQI, you look at the amiodarone protocol, the glycemic control protocols, the antibiotic prophylaxis, protocols that STS has recommended. A lot of them are very basic, but they're also very, very effective. And I don't know that as a organization that VCSQI could build, those protocols around using something that, that requires an investment, and I think the NephroCheck wasn't cheap. And so I think there are other things that we probably can focus on that are measurable and, that are easily put into a order set and via protocol, and, where we can generate compliance, very much like, AFib with amiodarone and blood transfusion, creating triggers, things like that. That would be my hope for how this protocol might look. And I think, although I've not seen it, I imagine like the blood conservation consensus statement by STS, that probably the renal protection consensus is probably going to look very similar in that regard.
I would, I think that's great. I would add a couple things that maybe I'd like to do up front. And number one is maybe resurvey the practices involved, both from the cardiology cath lab and from the cardiothoracic surgery OR perspectives, as to who's got AKI protocol, prevention protocols, and what they're doing. Because I think our information from a VCSQI standpoint is a little bit lacking. The other thing that I found from the cardiology standpoint is some pushback from interventionalists, at least on one of the VHAC regional meetings with regard to AKI, because the definitions may vary and are a little bit squirrely. So one of the things I think we need to do is make sure that we clearly define what NCDR definition is of AKI, what we're using from the surgical standpoint, STS standpoint as well, as we move across. So we have standard definitions, and when we're saying AKI, we know what we're actually talking.
I think that's a good point, and I can work with Sherry and the rest of the team to come up with, kind of a comprehensive survey to dig down and see who does have a protocol and where's the protocol sitting. I know that we have a hydration protocol, but in all honesty, I think it's very much like what you were saying. It's just built into the orders. It's not tailored. We're not really part of that. And so I think this gives us an opportunity to see what people may be doing in silos too, and come together as a group.
I know a number of interventionalists don't even like checking creatinines post-intervention, because if they get a little bit of a bump, even though it's clinically long-term felt not to be relevant, it triggers an AKI event.
Yeah. So that's probably a good first step is to create that survey, and I'll work with Sherry on doing that.
And
is there anybody?
The definitions.
Yeah, exactly. Is there anybody from the cardiology side on this call who might be interested? Chris, would you be interested? I know you kind of work both sides of the table. Is that something that you might be willing to partner with?
Yeah, sure.
Okay.
I'm already sending out a double question to our guys to see if we actually finalize the hydration protocol. We were talking about it, but I'm not sure it went. So yeah,
Okay.
I'd be very happy to help.
Sure, that'd be super.
Chris has great experience. She'd be a great person for the
Thank
two
you,
of
Dr. Shore.
Yep. Thanks.
Any other thoughts from the group?
I did want to share that I sent an email just now to Wayne Batchelor for Inova to see about getting more cardiology input, whether we get a fellow or we get an attending. But I think we need to have more direct cardiology involvement in this. And I think it would be good for the AKI work group and for VCSQI. So again, that's just a plug that in your institution, if you have someone you think might be interested, to reach out to them.
From our side at VCSQI, Dr. Shore, you mentioned some of the differing definitions of AKI between the two registries. Is there any data that we can provide? We can calculate, based on having the pre and post creatinine, and Chris has requested this before, we can create similar report metrics for AKI between the two registries. We can do drill downs, for instance, of AKI versus predicted risk or AKI versus pre-op creatinine levels. So are there any data views you think would assist in the committee's progress?
I definitely think that we should look to see if there is a correlation with anemia and in the cardiac surgery side with that pre-op crit before we go into the OR. I don't know if other people have custom fields where they are using the admission to ICU hemoglobin or hematocrit, but it would be nice to see if there's an opportunity to see if there's a relationship between that anemia and AKI.
Also, Eddie, I think you ran AKI with blood transfusions. I think I saw that data.
Yeah. But when you look at the Cleveland Clinic risk predictor, it pretty much drills down into, so EF, intra-aortic balloon pump, procedure status, so if it's emergent status, pre-op crit, greater than 1.2, and then it goes greater than 2.1. So it breaks it down into those two parameters, and it would be nice to be able to run that data against those predicting risk factors to see if there's a correlation in our data with that.
It would be very interesting to see if our data in real world supports that or is very, very different, and we use different cut points.
What we found, Mike, is that our preoperative, the STS preoperative risk score had very little to do with really what happens with the patients, because there's so much that goes on in the OR. And we had kind of floated the idea of looking at an intraoperative risk score to kind of adding in the intraoperative events to it, but we haven't, COVID, I think, has kind of stopped us on a lot of levels, but that was an interesting thought.
Mm.
I don't think we've ever done much with pump runs either, have we?
Not that I know of.
I think that might be interesting.
With what?
Pump runs, cross clamps, times in the OR, that kind of thing.
I mean, there is a lot of literature, obviously, saying that pump time and procedure time are very much related to AKI. Yeah.
Is there much literature between the timing of a cath and then going to the OR based on creatinine, et cetera?
I believe so.
Right. I've seen that data.
And I know that years ago, I had talked to Dr. Spear about that to see what Nova had done. And I think that there was I don't think it was a protocol, so to speak, but there was kind of a thought process that, if you have a creatinine that's, 1.4, 1.5, if that's their baseline, probably not horrible to proceed, within a couple of days of surgery. But if somebody's pre-op creatinine is 1 and then post-cath they're 1.4, you're going to wait 3, 4, 5 days to see it come down. You're going to hydrate. And that's kind of what we try to do. But here's where I think it would be great to have each hospital have a cardiology and a cardiothoracic surgeon from the physician side champion, so that there's that awareness. I think Dr. Schorb made a good point, because I know that our cardiologists know that we have a robust database in cardiac surgery nationally, but I don't know if they realize the implications of it. I know they probably realize the implications of their own data, but oftentimes, you're given a consult and the creatinine is 1.5, 1.6, and you're pushed to do these cases. Having everybody at the table and being able to share the consequences of those decisions, I think would be helpful, and probably help not only our data, but the data for the cardiologist as well, because our global awareness of it is going to be high.
One of the things, Eddie, you and Sherry can do is, of the cases that go to the OR, what is the timing from cath lab to the OR? That is it same admit? Do they get discharged and come back? So that we have a understanding of the volume of patients that we're talking about as well.
Very good. We can take a look at that.
On that is a lot of sites have now gone to only entering PCI because of the sheer volume of the data. So the cath to CABG data, it's really not there, unless Mike and Judy, you guys are doing something different. But we're doing only PCIs now in entry.
But you could get it from STS data. Eddie can just get it from our STS ACS data, because we have the date of the cath and the date of the surgery even if it wasn't done in the same.
Right, but the levels of the creatinine are not there.
Right, you would just have the OR entry one, right?
Right, so you can time it, but you don't know if it was based on creatinine, based on delirium, you know what I mean? It's going to be hard to pull that out.
But I do think it'd be useful just to look at the days between your cath and your surgery. Because I feel like I feel like people are getting away from that more and more, but maybe that's just a thought and not really true. It would be good to show that. That's a simpler, but I hear what you're saying. Chris, if someone is in the same stage, so they have a cath PCI and they go on and have cabbage, and then they have AKI, or raise their creatinine by 0.3 after their surgery, is that considered renal failure in the PCI database?
It's AKI. They don't consider it renal failure. They have an AKI.
Okay.
But
And
they
what
would
is that?
actually, they
what is-
separate out in the PCI database patients with CAB and patients without. So you actually have that easily pulled out. And Eddie's shown that. He's shown that PCI alone, PCI with CAB, and I think CAB alone, Eddie. I've seen those graphs because I've used them in our presentation.
Well, then that would be a good data point to collect for us in cardiac surgery, is just looking at elective cases versus urgent cases where patients have undergone cath before their surgery. I mean, it seems very obvious, but I don't know that we've thought of that. I don't know if Eddie, have you shown that data?
I have not shown it by status.
Yeah, I mean, that would be the only way to determine, but.
You could do it days from surgery, from cath also.
Yeah.
Yeah, I just wish we had a cleaner, because you're going to be looking maybe patients that were delayed for respiratory status, PFTs were bad, they want to rein them up, tighten them up. You got your diabetics with a hemoglobin A1Cs are bad. It's going to be tough to pull that out for renal failure. I think it's just going to be tough.
Yeah.
And then you got the patients that had P2Y12. It's just the delay, the time for cath to surgery is really tough to figure out why, unless you had the cath data in the database. And maybe there are still a lot of cath patients in there, but I know we don't collect that. We haven't for a year.
You're not putting your cath data in your STS database?
We're not in the ACC database.
Yeah.
We do not put cath patients, only PCIs.
Okay. Yeah. I heard you say that before, but you are putting your cath data in your STS database though, right?
Yes. Oh, yes.
Yeah.
Yes.
Okay.
But you don't have the creatinine level. You know what I mean? It's going to take a lot of work. I think the databases are so vital, and we got so much data to think about. I think really with the help of Eddie, we could do some really good presentations.
Do we have the opportunity to request that the creatinines be put in the STS database?
We do. We can do that with ARMIS.
The pre-creatinines we already put in there, Dr. Shore. Are you talking about a cath piece, cath creatinine?
Yeah, I was wondering whether or not there was any way to add that piece.
Yeah.
We could add, a pre-cath and a post-cath creatinine.
Right.
And I have to say, I don't know if some of these fields for us are custom or if they're standard, but
Those would be custom.
We also have the highest creatinine, the creatinine, the most recent creatinine before they go into the OR. And then we also have a peak creatinine post-op, obviously. I think that's standard in STS. So, but I think
right. But I'm also wondering for caths now, are they doing a lot of pre and post creatinines for straight cath?
No, we don't.
The answer is
I think that's what AKI looks
probably
bad.
not.
Yeah.
They have to have at least a pre. I mean, there's usually a pre.
Right.
To make sure someone doesn't have, acute renal failure or something. But the post creatinine is one that I'm not sure how diligent they are in obtaining that.
And how close to the cath post-op Dr. Shore, would you want that to be? Like the following day, or would you want to see what the peak post-cath creatinine was?
Yeah, I think we have competing imperatives in that I think many of the operators don't want any of their patients to have AKI
Right.
in it. So they're trying to time, if they obtain a post-cath blood sample, they're trying to time it so that it's not going to have an opportunity really to go that high. So,
Right.
I'm just not sure how we're going to necessarily manage that. The sick patients are going to be in the hospital. They're going to stay often and then go from the cath lab to the OR. But some of the less sick people, we're going to have a pre-cath and we'll have a pre-OR, but we won't necessarily have something in between.
Yeah, that reflects true contrast nephropathy.
And whether or not that would then predict an OR event is uncertain.
Right.
That missing data.
Right.
Yeah, because the cath docs, as you know, they're getting patients in and out. They don't really want them in the hospital. They're same-day discharge, and so their creatinines are not being measured.
Right. And we don't do it as an
makes you-
outpatient. We don't have them come back to the office and say, 2 days later, we want you to get your post-cath creatinine.
Right.
That's not happening.
No.
Right.
No. I know that there is literature out there that does demonstrate that if a patient has even mild nephropathy post cardiac surgery, their long-term survival is moderate to severely decreased. And so I don't know if there's been any studies post-cath that have demonstrated that, but I think, it definitely, the data out there supports us taking this to the cardiologist and sharing that knowledge, because out of sight, out of mind is great, but if there's a long-term detriment to patients, it's something we definitely should be looking at. And we can go to ARMIS and have them create these fields, but as you mentioned, Dr. Shore, the big ask is going to be having cardiology make it a standard practice to measure that post-cath creatinine. So again, getting back to that question, would it be we would just do serial BMPs, creatinines in the days following cath, and then stop doing them once the creatinine has reached its baseline?
Well, I think if you have someone who is going into it with an elevated creatinine, those patients are going to get, and they're sick enough to be in the hospital, they're going to get follow-up creatinines. I think part of the concern from the cardiologist standpoint is going from 0.9 to 1.2 when they might have been dehydrated is not a reflection of acute kidney injury.
Exactly.
And so the concern from the cardiologist is that a valuable measure? Now, on the other hand, you go from 1.4 to 1.7, where someone's already starting with renal insufficiency, that may be a different animal. So that's why I think making sure we all understand the definitions is helpful. And I frankly, Mike, love the idea of sharing all those articles you've been citing with the work groups so that we're working from a common baseline as well.
Yeah.
We have 10 minutes left. Other things that we want to talk about or to bring up for the next meeting?
I think
Sherry,
the thing
Eddie,
we need to
we-
do, Mike,
What's
is
that?
maybe get with Eddie and do
Yeah.
a list of the data that we think is important for the next meeting.
Yeah.
And we included, by the way, I think they just flashed it, but that was the ACC's update on AKI and CAT, procedural strategy. So this was the article 2019 that from Jack from Journal American College of Cardiology.
Mhm.
So everyone should have that.
Yep, and I thought it was a good article. I'm also going to share an article tomorrow, this evening, when I get back to my office, and I'll share a couple articles on what I was talking about earlier, just about perioperative and postoperative blood pressure control in patients with hypertension. It just seems like the most basic thing that we could be doing, but I think that just at times we're probably not consistent doing, as a practice. And I'll share that article with you all as well. Eddie and Sherry, is there something you think that is there something missing you think that we could focus on, or that we could look at from a data standpoint?
Not from my perspective. I believe you covered a lot to start with. Eddie, what are your thoughts?
Yeah, I agree. This sounds like a great starting point. I'm sure when we meet, and we can look at all the data elements kind of side by side alongside some initial reports, we'll come up with some more thoughts. But to me, let's start there and then kind of see how it blossoms.
Good. Very exciting.
Yes, indeed.
We have a couple slides tonight too about AKI versus access site and the cath-PCI predicted risk of AKI. So that'll be interesting too.
Yeah, and that was also in that article that Sherry shared. So. Well, I don't know that I have anything additional to add. So if you guys think that we can dismiss the group, whatever your thoughts.
Thanks, Mike. Thanks for sharing
Thanks.
this, because it's a tough group.
Yeah, I'm pretty excited. So thank you guys all for your commitment. And if you know anybody else within your practices that'd like to be involved, I think the more voices and ideas, the better we'll do, and more traction we'll get. So.
Thanks. Does anybody else have any comments, suggestions, upgrades?
No, I think it all sounds great. Thank you all.
Okay, great.
Okay.
Thank you so much, everybody.
Yep.
Okay,
Thank you guys. See you.
Have a good evening.
Thanks.
Bye.